Hello class, today we are going to start with a new topic, that is chronic obstructive pulmonary disease, which is also known as a COPD. So let us see the definition of COPD, or chronic obstructive pulmonary disease. So chronic obstructive pulmonary disease or chronic obstructive airway disease is a commonly used clinical term for a group of pathological conditions in which there is chronic, partial or complete obstruction to airflows at any level from trachea to smallest airways, resulting in functional disability of your lungs. So COPD is also known as a chronic obstructive airway disease, and when we say that this is a group of pathological conditions, it means that it does not contain only just one disease. So there are other diseases which comes under COPD, and always in case of all your COPDs there is chronic, partial or complete obstruction to your airflow. So it is affecting your flow of your air inside your from in your respiratory tract, and this can start from any level from your trachea to your smallest airways, that is till your terminal alveoli. Okay, and whenever you are suffering from COPD, it will result in functional disability of your lungs. Okay, whenever we talk about COPD is a progressive disease. So with time this disease is going to progress more and more, and it is seen that it is more common in patients with those who smoke. It is common in smokers than in people who do not smoke. Okay, so let's talk about your first COPD disease, that is your emphysema. So what is emphysema? Emphysema is one of your COPD. So emphysema is generally characterized by loss of lung elasticity and abnormal enlargement of your air sacs or air spaces distal to your terminal bronchioles, with destruction to your alveolar walls and capillary beds. So whenever we talk about emphysema, see, in case of emphysema there is going to be loss of your lung elasticity is lost, and abnormal enlargement of air spaces is going to take place distal to your terminal bronchioles. Distal to your terminal bronchioles comes your respiratory bronchioles. So it is affecting your respiratory bronchioles, in which there is loss of your lung elasticity as well as no abnormal enlargement of your air spaces, generally because there is destruction of your alveolar walls, capillary beds, as well as your extracellular matrices in these areas. Okay, and whenever we talk about emphysema as well, since there is abnormal enlargement of your air spaces, this generally leads to your hyper inflation of your lungs, and in case there is an increase in your total lung capacity as well. So when we talk about emphysema is divided into four major types. Okay, and those four major types are: first one is a centriacinar or centrilobular, second one is a panacinar or panlobular, distal acinar, and a irregular emphysema. So let us see what each and individual types of emphysema generally is. So when we talk about central acinar or central lobular, this type of emphysema is more common in case of your smokers. So people those who smoke, they generally tend to form centriacinar or your centrilobular emphysema. Okay. Other than that, centriacinar or centrilobular is 20 times more common than your panacinar emphysema. Okay, more common. It is 20 times more common than panacinar your emphysema. In case of centriacinar, there is your center or your proximal parts of your acini of your lungs is affected. Okay, and generally your respiratory bronchioles get affected. Okay, your central part or your proximal parts of your respiratory bronchioles are affected, not your distal parts. Okay, so again, your central part or your what you call your central or your proximal part is getting affected, and not your distal part. So when we talk say proximal part, it means closer to your terminal bronchioles, and this generally affects your upper lobes of your lungs. Second is your pan-asthma. Okay, whenever we talk about pan-asthma, this is more common in patients who are suffering from alpha 1. This is alpha 1 antitrypsin. This is more common in patients who are suffering from anti-1 antitrypsin deficiency, and this is more common in your respiratory bronchioles from to your in your areas of your terminal alveoli. Okay, so you're more common seen in patients suffering from anti-1 antitrypsin deficiency from your respiratory bronchioles towards your terminal alveoli, so more common towards your lower halves or your lower lung zones. When we talk about all four types of emphysema, these two types, your first and your second types, are more significant clinically than the other two. Third one is your distal acinar emphysema. When we talk about your distal acinar, in this case your proximal portion is normal. Proximal portion of your acini or your acinus of your lungs is generally okay, it is normal, but in this case there is going to be damage towards your distal parts. Okay, your lower half of your lungs or of your respiratory tract is damaged in case of your distal acinar, whereas in case of irregular, it appears at irregular areas. So whenever we talk about different types of emphysema, your first two are more common. Type 1 more common in case of your smokers, whereas pan-acinar more common with alpha-1 antitrypsin deficiency patients. So let us see. See, this is your diagram of your alveoli or your respiratory bronchioles, showing you your centri-acinar emphysema and your pan-acinar. See, centri-acinar, see, you can see it is affecting your proximal area and your upper parts, whereas your pan-acinar is affecting your lower parts and your mostly your alveolar areas, your alveoli. Okay, so there is another diagram. See, this one makes it more clear. Centri-acinar towards your proximal parts, okay, upper parts, whereas pan-acinar more towards your lower areas, and your alveoli are getting affected. Okay, terminal alveoli in case of your pan-acinar. So this is just a diagram to show you your difference between your centri-acinar and your pan-acinar. Next we come to your pathogenesis. So if you see this diagram, two important causes, okay, for your production of your emphysema are: number one will be your environmental exposure, that is, it can be to your tobacco smoke, biomass fuels, and other exposures to your pollutants. Okay, and the other one will be your genetic factors, and when we talk about genetic factors, it is either your TGF beta 1 polymorphism, that is tissue growth factor beta 1 polymorphism, and another one is alpha 1 antitrypsin deficiency. So let's talk about your pathogenesis. So whenever we talk about environmental factors, most important environmental factor, smoking. Okay. Other than your air pollutants, most important one is your smoking. So let us talk about what happens whenever you smoke. Okay, say we are smoking, what happens, you take in your smoke. Smoke is something that is unwanted by your body. So generally what happens, due to the smoke, it is going to induce inflammation. Correct? You smoke, goes to your lungs, it induces inflammation. So whenever there is inflammation taking place, there will be accumulation of your inflammatory cells. I smoke, smoke goes into my lungs, inflammation is going to take place in my lungs, so there is going to be involvement of my inflammatory cells. So in this case, normally your inflammatory cells will be your neutrophils, your macrophages, and your lymphocytes. Okay, so these get accumulated in your lungs, and these inflammatory cells, what they generally do is they are going to release their chemical mediators as well. So they will release the cytokines. Okay, there is going to be a release of cytokines, and there is going to be release of proteases. One of your most important protease that is getting being released in this case is your elastase. Okay, one of your important protease being released is your elastase, and this elastase is responsible for degrading. Okay, I am writing it here. Is responsible for degrading elastin. Okay, again I'll repeat it. You smoke, inflammation is going to take place. Since there is inflammation taking place, there is going to be your inflammatory cells are going to get involved. So your inflammatory cells that are getting involved is your neutrophils, your macrophages, and your lymphocytes. Okay, so these inflammatory cells are going to release the chemical mediators as well, so which are your cytokines and your proteases. One important protease that it is releasing is elastase, and normally this elastase, what it does is it goes and it degrades your elastin. Okay, so these proteases, what they do is they are going to degrade your extracellular matrix. Okay, it is degrading your extracellular matrix. So degradation of your elastin will further lead to, okay, I told you elastase is going to degrade elastin. So whenever elastin is getting degraded, it will, your degraded product of elastin will further induce inflammation. Okay, elastase degrading elastin, it will further induce the process of inflammation. So more inflammation is going to take place. So degradation of your extracellular matrix is taking place side by side. Whenever your extracellular matrix is getting degraded, okay, we come to your another factor. Okay, we are talking about your protease, that is your elastin. So normally your body has a protective function as well. Okay, we won't be talking about your epithelial cell injury right now, mesenchymal cell injury right now. We will just talk about elastin right now. So whenever your elastin is being produced, right, it is very harmful to your body, as well as other oxidizing agents are being produced in your body. Your body generally produces antioxidants for your oxidizing agent, whereas elastase that is being produced in your body is generally blocked by alpha 1 antitrypsin. Okay, we talked about alpha 1 antitrypsin as being one of your genetic factors. So alpha 1 antitrypsin, generally what it does is it goes and it blocks your elastase. It is going to block your elastase. So if patients or people are suffering from alpha 1 antitrypsin, do you think deficiency, do you think alpha 1 antitrypsin is going to block elastase? No, they are not going to block. So elastase can rampantly go and destroy your cells of your respiration of your lungs, correct? So this will further lead to emphysema again. So this is how your alpha 1 antitrypsin deficiency leads to your emphysema. See, alpha 1 antitrypsin goes and blocks elastase. What was the role of your elastase? Elastase was degrading your elastin. So whenever elastin was getting degraded, it was inducing inflammation, and as well as elastin is one of your major component of your extracellular matrix as well. Apart from these, there are other proteases being released as well. So these proteases are going to damage your epithelial cells, right? So damage to your epithelial cells takes place, due to which there is going to be apoptosis or necrosis. So your epithelial cells are dying as well. Now lastly we come to another thing, that is your TGF beta 1 polymorphism. TGF beta 1 polymorphism, genetic factor. So generally TGF beta 1, okay, tissue growth factor beta 1, helps in what? It helps in signaling, right? It helps to give, it helps in signaling, and it generally induces your process of your repair. Okay, it is going to help in your process of your repair, that is your TGF beta 1, what it generally does is TGF beta 1, it is helpful in sending information, and since this is a growth factor, this helps signaling sent by TGF alpha beta 1 helps in your process of repair and regeneration. But in this case what is happening is you are having TGF beta 1 polymorphism. So we have a dysfunctioning TGF beta 1. Since you have a dysfunctioning TGF beta 1, what happens is your mesenchymal cells, okay, of your lungs, they do not respond to your tissue growth factor beta 1 signals, thereby your process of repair and regeneration is hampered. Inflammation, damaging ECM, apoptosis and necrosis of your epithelial cells, as well as your damage of your mesenchymal cells, in the end leads to alveolar parenchymal destruction. So thereby you have your disorder or your disease of emphysema. So your same diagrams is stating the same. Your smoking is here. So in short, we'll see once again. You are smoking, you're going to attract your inflammatory cells. Smoking can directly decrease your activity of your alpha 1 antitrypsin activity as well. So whenever there is attraction of inflammatory cells, it is going to release elastase. So again I said, whenever there is release of elastase taking place, so first and foremost, if you have normal functioning of your alpha 1 antitrypsin, activity of your elastase is getting blocked by your alpha 1 antitrypsin. But if there is deficiency, in this case if we have a inherited deficiency of your alpha 1 antitrypsin deficiency is there, so your elastase is not going to get blocked, thereby there is going to be destruction of your elastic fibers in your lungs. Otherwise, since smoking is causing decrease in your anti-1 alpha trypsin activity, your elastase is going to work and it is going to destroy your elastic fibers of your lungs, thereby you have your emphysema. So this is your pathogenesis of your emphysema. So next we come to another disease or another disorder, which is chronic bronchitis. So generally what is chronic bronchitis is, whenever any person says he's suffering from chronic bronchitis, there is a specific indication to it. So chronic bronchitis, it is defined by the presence of persistent productive cough for at least 3 consecutive months, that is 3 continuous months in at least 2 consecutive years. So it is a persistent productive cough, correct, for 3 months. It should last for at least 3 months and should appear in 2 consecutive years. So if anyone is suffering through a productive cough for at least 3 consecutive months and for at least 2 consecutive years, then a person is said to be suffering from chronic bronchitis. Okay, so what do you mean by productive cough? So it is a productive cough because your mucoid sputum is being produced But generally in your early stages, your airflow is not obstructed by this sputum. But as it goes on and progresses, as it becomes chronic then you see obstruction in your airways. And whenever we talk about your COPDs, in case of chronic bronchitis also, it mostly is affected while you exhale. There's a problem when you exhale rather than when you inhale. Okay. Again, etiopathogenesis. In this case also, in case of chronic bronchitis, smoking is one of your major cause. Those who smoke, 4 to 10 times more common in person or in people those who smoke than with patients or person who do not smoke. Okay, more common with smokers. Second cause is your atmospheric pollutant or pollution. Now, when we talk about atmospheric pollution, it has been seen atmospheric pollution as being a cause because more common in urban areas where there is air pollution than in areas that is in your rural areas. Urban areas are more polluted, and it has been seen that chronic bronchitis is more common in urban areas due to air pollution rather than rural areas where air pollution is not there. Third is infection. Bacterial infection can lead to your chronic bronchitis as well. Fourth, occupation. When we talk about occupation, people working in mines, cotton fields, where pollution is high, or you may get affected by your air pollutants, so can lead to chronic bronchitis as well. Familial and genetic factor, not much common, but it can be transferred from parent to offspring, but not so significant. So let's talk about your chronic bronchitis pathogenesis. One of your most distinctive feature of your chronic bronchitis is hypersecretion of mucus. Okay, so there is going to be hypersecretion of mucus. That is, there is increased secretion of your mucus in your respiratory tract, and this secretion of your mucus can start from your larger airways itself. It does not have to reach to your it does not have to start from your respiratory bronchioles. Before that also it can start. Okay, and the beginning is from your larger airways itself. Okay, so whenever you smoke or whenever there is any environmental irritant entering, okay, let's consider smoke, because smoking is one of your most important cause. So this smoke is going to act as your irritant. Okay, this is an environmental irritant. So whenever you smoke or any air pollutant enters into your lungs, what they generally do is they irritate your surface of your respiratory tract. And since your smoke is unwanted as well and it is causing irritation as well, what happens, these irritants are going to cause hypertrophy of your mucus glands. Okay, your size of your mucus glands increases. Okay, so if this is your mucus glands, in case of smokers, after getting irritated, your size of your mucus gland increases. So this increases from your level of your trachea and in your main bronchial itself, as well as this is hypertrophy. So size is increasing of your mucus gland, as well as there is going to be hyperplasia as well. So generally hyperplasia of your goblet cells appears. So your number of goblet cells secreting mucus increases. So there is hypertrophy, there is hyperplasia. So both these cells are producing what? They are producing mucus, right? So if their size and your number increases, what do you think will happen? Your amount of mucus getting secreted is going to increase. Again, I'm repeating, there is hypertrophy of your mucus gland. So if this was the size of your mucus gland, after smoking your size increased. Okay, so this size amount of mucus gland is going to produce increased amount of mucus. Secondly, initially there were just 2 mucus secreting goblet cells. After smoking, this becomes 6 or 7. Okay, so your amount of mucus being secreted by these cells is going to increase as well. So both these factors leads to what? They are going to lead to increased mucus secretion. Okay, they are going to lead to increased mucus secretion as well. Not only does this lead to increased mucus secretion, secondly, you are talking about smoke. So whenever you smoke, it is going to cause inflammation as well. So whenever we talk about inflammation, there is going to be involvement of your lymphocyte, macrophages, and neutrophils as well. So there is inflammation, and there are other inflammatory cells which accumulate in that area as well. So in your respiratory tract, it has a ciliated, covered by a ciliated epithelium. Okay, now you are secreting mucus, so it is this ciliated lining, it is going to get covered by mucus. Generally, your function of your cilia is to propel your mucus up for it to get expelled, correct? Your lining of your respiratory tract, this is your respiratory tract, you are inhaling, air is going inside, you have your ciliated so you have your ciliated epithelial lining. So whenever mucus is I'll draw your mucus in another color. Whenever mucus is accumulating in your respiratory tract, what this does is cilia does it is going to send it up, correct? It is going to send it upwards, right, to throw it out from your mouth. So in case over here, what generally happens is, now you have your inflammatory cells, your leukocytes, you have your macrophages, you have your monocytes. Now in case of chronic bronchitis, your mucus has increased tremendously. Okay, there's an increased amount of mucus. So this mucus is going to entrap your leukocytes, it is going to entrap your neutrophils, as well as it is going to entrap your macrophages. So generally, in due course of time, what happens? Your cilia of your epithelial cell gets damaged. So when your cilia gets damaged, this mucus cannot be propelled out from your respiratory tract. So if your respiratory tract cannot propel out your mucus from your respiratory tract, what happens? It is going to stay in your respiratory tract. So there is going to be blockage. So this is generally what happens in case of your chronic bronchitis as well. Okay, so there is hypertrophy of your mucus gland, as well as there is going to be hyperplasia of your mucus secreting goblet cells. Thereby there is going to be increase in your mucin secretion, as well as there is inflammation. So there is going to be lymphocytes, macrophages, and accumulation of your neutrophils. So generally the morphological pieces of your outflow obstruction of chronic bronchitis results from small airway disease, goblet cell metaplasia, that is increased amount of your goblet cells with mucus plugging of your bronchial lumen. I already told you why there'll be mucus plugging. So they are going to lie a mucus cell. In due course of time, your neutrophils, they are going to damage your ciliary lining. So if they are going to damage your ciliary lining, your mucus does not come out from your respiratory tract, it stays back, so you are having an obstruction to your airflow. And whenever we talk about your emphysema and your see, there is coexisting emphysema. Whenever we talk about emphysema or your chronic bronchitis, they are basically overlapping each other. So a person suffering from chronic bronchitis, they generally suffer from emphysema, or it's the other way around. So most people suffering from emphysema, they generally suffer from chronic bronchitis. So these two diseases, they interlap each other, they overlap each other as well. Clinical features that you generally see, so there's persistent cough with copious expectoration of long duration. Recurrent respiratory infections are common. Dyspnea, that is, you know, your difficulty in breathing, generally not prominent at rest but more on exertion, so whenever you do more exercise. Chest x-ray shows enlarged heart with prominent vessels. So enlarged heart because your heart is to do more functioning to pump blood, because your oxygen, there is a blockage in your airways. Next we come to your asthma. Okay. Okay, so next topic that we are going to do is asthma. What is asthma? So asthma is a chronic inflammatory disease of your airway. Okay, it is a chronic inflammatory disorder, so of your airway, that causes recurrent episodes of wheezing, okay, breathlessness, chest tightness, and cough, particularly at night or early in the morning. So this is a general definition of your asthma. We are going to talk about each one. Okay. So it is a chronic inflammatory disorder. One major difference in this is, since there was inflammation in case of emphysema as well, there was inflammation in case of your chronic bronchitis as well. The only difference in your inflammation in case of your asthma is, see, in both your cases, emphysema and your chronic bronchitis, eosinophil. In both cases of your chronic bronchitis as well as in case of emphysema, there was no involvement of eosinophils. But in case of asthma, there is involvement of your eosinophil. Okay, so we'll talk about it. General hallmarks of your disease. In case of patients suffering from your asthma, what do you generally see in patients suffering from asthma? So first and foremost, it is an intermittent and reversible airway obstruction. It is reversible, okay, whereas emphysema is non-reversible. Chronic bronchitis is non-reversible, but asthma is reversible to a certain degree, right? Chronic bronchial inflammation, so there is going to be inflammation of your bronchial of your airways with eosinophils. Emphysema does not have any eosinophils, okay, there's no eosinophils involvement, as well as your chronic bronchitis also is not involved with eosinophils, but asthma is. There's hypertrophy of your smooth muscle cells of your bronchi, as well as there's hyperreactivity of your bronchi, as well as lastly there's increased mucus secretion. There's increased amount of secretion of your mucus. So let us see what generally happens in asthma. So etiopathogenesis and types. Asthma is divided into two basic types. Okay, there are two types of asthma. One is extrinsic and the other one is intrinsic. But first we'll talk about your extrinsic or your atopic asthma or allergic asthma. So okay, so one of your most common type of your asthma that you see is your extrinsic atopic or your allergic asthma. So this is your most common type of your asthma, and this is generally indicated by type 1 hypersensitivity reaction. I think it's here. Okay, so it is generally indicated by type 1 hypersensitivity reaction, and whenever type 1 hypersensitivity reaction is involved, there is increased amount of IgE, that is immunoglobulin E. There is increased exposure of increased level of your IgE in your serum. Okay, most common, it is most common mainly because of type 1 hypersensitivity reaction. And whenever we talk about your extrinsic or your atopic allergic asthma, there is increased level of IgE in your serum. And this type 1 hypersensitivity reaction or your asthma is divided into two phases, that is your acute immediate phase or your acute immediate response, or your late phase reaction or your late response. Okay, hypersensitivity reaction is a most important cause. And whenever you see any people suffering from extrinsic or atopic asthma, they generally have other allergic disorders as well. So they may be suffering from hay fever, and other allergic disorders are also seen in patients who are suffering from atopic or allergic asthma, and this is most common type of asthma that you see. I think this picture is clear. So you're coming to your pathogenesis of your asthma or your extrinsic asthma. First and foremost, since this is being induced, this is because of your hypersensitivity reaction, you have to have an allergen coming and inducing it. So this is blocking. So this is your antigen. Okay, so this is your allergen. So whenever they enter into your cell, in this case, see, they are activating your dendritic cells. Okay, your dendritic cells are getting activated. And one most common thing is, in case of your uh, extrinsic type of your asthma, there is increase in your number of your type 2 helper cells. Okay, so there is going to be increased production of your type 2 helper cells. So this is your Th2 over here. Okay, so there is increased, I'll make it with another color, green. Okay, so this is your T2 cells, this is your type 2 helper cells. You are getting type 2 helper cells. So you are getting affected by an allergen. An antigen comes, it activates your dendritic cells. So due to this allergen, what is happening is there is an increased amount of type 2 helper cells, and this type 2 helper cells, they produce different types of cytokines. They release different cytokines. So they are going to release IL-4. Okay, see over here, you can see this is your IL-4, interleukin 4. It releases IL-5. Okay, it is over here, IL-5, as well as it releases it, which is not there in your figure, it is going to release IL-13 as well. Okay, Th2. Okay, this is a helper cell type 2, releases different cytokines. So those cytokines, again I'm show it to you: IL-4, interleukin 4, IL-5, interleukin 5, as well as IL-13. So it is releasing 3 different types of interleukins. Now these interleukins have own specific functioning. So what do they do? So when we talk about IL-4, okay, I think this green will work. So when we talk about IL-4, activation of your cytokine or release of your cytokine IL-4 increases your production of your IgE. Okay, so there is because of release of your IL-4, this goes and this increases your production of IgE. When we talk about IL-5, whenever there is increased production of IL-5, it increases your recruitment of your eosinophil to your area where there is any damage taking place or wherever it is to be recruited or IL-5 is being secreted. Okay, IL-4 increasing your production of your IgE first, IL-5 increasing your recruitment of your eosinophil. Okay, and lastly there is your IL-13. So whenever we talk about IL-13, whenever there is an increased production or secretion of IL-13, in this case in your respiratory tract, it is going to lead to increased mucus production. Okay, there is going to be increased mucus production. Okay, so this is your simple initiation. Allergen coming, activating Th2 liberating your cytokines IL-4, 5 and 13. 4 increasing your production of your IgE. 5 increasing your recruitment of your eosinophils, so there is going to be more eosinophil in that particular area, and IL-13 increasing your mucus production. So let's talk about your so let's talk about what your IgE does. So whenever there is increased amount of IgE, first we are going to talk about your what you call it we are going to talk about your acute immediate response. Okay, first in case of acute immediate response, so first is your acute immediate response. In case your allergen comes, it activates your Th2, so there is increased amount of eosinophil recruitment taking place, as well as IgE is getting increased, as well as mucus is getting secreted. Okay, this is your general functioning. So first and foremost, acute phase generally activates within 10 to 20 minutes. Okay, so it activates within 10 to 20 minutes. So you have IgE being produced in excess amount. So this IgE, what it does is it goes and it okay, I'm drawing way too first. Let me draw. It goes and it covers your mast cell. Your mast cell is there. Okay, your mast cell is there. Your IgE is okay, your IgE is here. So what is the IgE do? It goes and it covers your mast cell. Because of this, your IgE going and activating your mast cell, what generally happens is mast cell is going to mast cell going and activating your IgE going and activating your mast cell. So activation of mast cell leads to its degranulation of your mast cell takes place. Because there is degranulation of your mast cell taking place, your mast cell is going to liberate chemicals from inside of its body. So there is going to be release of histamine. H stands for histamine is going to get released. Leukotrienes, prostaglandins are going to get released. Platelet activating factors is going to get released, as well as your chemotactic factors are going to get released. Okay, Th2 activating, causing increased production of your Ig. Ig goes and acts on your mast cell, causes its degranulation. Due to degranulation occurring, it is going to release chemical substance. So there is going to be release of histamine, leukotrienes, prostaglandins, platelet activating factors, as well as the chemotactic factors. Because of this, what happens is there is going to get because of this there is going to be infiltration of your inflammatory cells on your mucosal intracellular junction. Okay, because of your factors be getting released, okay, there is going to be infiltration by your inflammatory cells on your mucosal intracellular junction. As this happens, what happens due to this, there is going to be excess your antigen gains and access to your submucosal areas of your excess of your antigen becomes more gains and access towards your submucosal parts of your airway tracts. Okay, so it was releasing histamine, prostaglandin, platelet activating factor, chemotactic factors as well. So histamine can cause constriction, so it can lead to bronchospasm. So there is bronchospasm also occurring side by side. Now this bronchospasm occurs not only because of your release of your because of your release of your histamine, but can also be caused due to activation of your parasympathetic receptors as well. So there is activation of your parasympathetic receptors as well. Apart from that, other effects that you generally see is there is going to be edema occurring. Edema occurs because there is going to be increased vascular permeability, increase in your vascular permeability, as well as there is increased mucus secretion. So this is your mechanism of your response in your acute phase, which occurs within 10 to 20 minutes. Again, I'll repeat it. Antigen comes, activates your dendritic cells. Due to your activation of your dendritic cells, there is going to be increased production of your type 2 helper cells. Type 2 helper cells releases chemokines. So normally your interleukin 4, interleukin 5, as well as your interleukin 13. Interleukin 4 goes and increases your production of your IgE. Interleukin 5 brings in your eosinophils, whereas 13 increases your mucus production. So since what does your IgE do is IgE goes and it activates your mast cell. So activation of your mast cell by IgE increases your infiltration of your inflammatory cells on your mucosal intracellular layer or your intracellular junction. So there is an increased excess of your antigen. Apart from this, mast cell is also liberating histamine, leukotriene, prostaglandin, platelet activating factor, chemotactic factors as well. Apart from this, side by side, whenever asthma is occurring, there is going to be bronchospasm. So bronchospasm generally occurs, histamine is getting released, so it can lead to bronchospasm. Other than that, it is going to there is activation of your parasympathetic receptors, which will also lead to bronchospasm. Apart from that, there is edema occurring in your mucosal layers. So there is edema. Lastly, there is increased mucus secretion. Now, one of your major role of your eosinophil in this case is eosinophils can destroy your epithelial lining. Okay, so they not only destroy your epithelial lining, they also destroy your you see this diagram. In this diagram, your cilia is getting affected or they are getting damaged. So your eosinophils can damage your ciliary linings of your cell as well as the epithelial lining of your respiratory tract. This is just your acute phase response. Next comes your chronic phase or your late phase response. Whenever we talk about your late phase response generally takes around 4 to 8 hours to develop. Okay, so in case of late phase response, it is all about inflammation. It involves inflammation. Okay, and it generally prolongs your asthma attack. It prolongs your asthma attack for a long duration of time, and your response can take up to 12 to 24 hours. It can last up to 12 to 24 hours. So initial trigger for your late response. Okay, initial trigger for your late response is basically because of your inflammatory mediators being released by your mast cell. So in case of early phase response, there was degranulation of your mast cell taking place. So whenever there is degranulation of mast cell taking place, it was releasing various substances as well as it was releasing inflammatory mediators as well. So because of this, what happens is, due to your release of your inflammatory response, there is going to be increased amount of migration and activation of your inflammatory cells. I hope you are getting it. In first phase, we were talking about first phase. First phase, we didn't talk about inflammation as much. Okay, mast cells and their reactivity causing damage. Second phase, mast cells were releasing chemical substances, mediators, due to which there is going to be increased amount of migration as well as increased activation of your inflammatory cells. So there is going to be accumulation of neutrophils, basophils, eosinophils, and all these inflammatory substances, what they generally do is they are going to damage your epithelial lining, or your epithelial injury is going to take place. So that's why if you see in this case acute, there is not much damage because inflammatory cells were not so much involved and there was not much migration and accumulation taking place. But in case of late phase injury, there is much more accumulation of your inflammatory cells and activation as well, due to which there is damage to your mucous cells. Your mucous cells, they generally go under hypertrophy, so they produce more amount of mucous cells, whereas your epithelial injury leads to damage of your cilia, so your mucus is going to form a coat. So since there is decrease or damage to your epithelial cells, there is going to be decrease in your clearance, or your propelling activity is hampered, so mucus gets stuck in your respiratory tract. Okay, so this is generally your acute and your late response. Again, same thing diagram explaining in another way. So early phase response, there is a allergen activates your mast cells. So generally T helper 2 cells activating mast cells, releasing histamine, leukotriene, interleukins, prostaglandins, which can cause bronchospasm. Okay, so other cause for bronchospasm, I told you, parasympathetic activation. So bronchospasm itself can limit your airflow, correct. So apart from that, there is infiltration of inflammatory cells, release cytokines, interleukins, and then other inflammatory mediators. This is going to bring in more amount of inflammatory cells, which will be responsible for your late phase response. So because of your release of your cytokines, interleukins and other inflammatory mediators, there is going to be infiltration by more amount of inflammatory cells. So there is airway inflammation taking place. Whenever inflammation is there, there is bound to be edema because your fluid is going to get lost. Epithelial injury, impaired mucociliary function. Because of all this, your mucus is not going to get removed, your clearance is not going to take place, so it is going to line your respiratory tract. Airway inflammation is also causing increased airway responsiveness. Okay, so this is your general diagram. Another one, same thing getting explained. Okay, from top to bottom, any diagram that you want to follow from all these three diagrams explains everything in detail. Next is your intrinsic, idiosyncratic or non-atopic asthma. So generally this type of asthma develops later in your adult life. Negative personal or family history of any allergy. This is not caused by any allergy. Okay, so intrinsic or non-atopic asthma, your triggers for this type of asthma includes respiratory so may be caused by respiratory tract infection. Okay, maybe be caused by exercise, hyperventilation, cold air, drugs, chemicals, hormonal changes, and emotional upsets, airborne pollutants, and esophageal refluxes. Okay, so all these things can lead to your production of your atopic, non-atopic asthma. Okay, so when we talk about your respiratory tract infection, generally this respiratory tract infection is because of your infection by any viral antigen. Okay, so it is basically by your more common because of your viral antigen, and this viral antigen can generally increase the level of IgE in your respiratory tract, and thereby it goes and causes asthma. Exercise, and whenever okay, we'll just talk about few. So when we talk about exercise, so how can your exercise cause asthma is, so whenever you are exercising, what happens is there is going to be increased inhalation. Okay, so there is increased inhalation taking place, as well as there is going to be increased volume of air being inspired. Correct? You are exercising, so you inhale more, you take in more volume of air, and it is generally seen that exercise can lead to asthma more commonly in case this exercise is being performed in a cold region, or you are breathing in cold air rather than in normal air. Okay, again I'll tell you, exercise can lead to asthma, but it has been seen that exercise can lead to asthma. Leading to asthma is more common whenever exercise is being done in a cold area where you breathe in cold air. So let's see how it causes it. So you are exercising, you inhale more amount of air, increased inhalation is there, so there is going to be increased volume of air you are going to breathe in as well. So since you are in a cold area, so your mucous lining of your respiratory system, okay, I breathe in. So your main function of your mucous system, your hair, what do they do? It is to if it is your air is dry, it is good. It helps in moisturizing your air, your environmental air. If your air is cold, it increases your temperature of your air before it enters into your lungs. But in this condition, what is happening is you are exercising, so you are taking more amount of air, more volume of air in a very short duration of time. So because of this, your air is not humidified properly, your air is not heated properly. So when it enters into your respiratory tract, what happens is it is going to cause your cause inflammation. Okay, it is going to cause inflammation. Why it causes inflammation is it is going to go and your sensitivity of your respiratory tract increases because your air is not under normal condition, it is cold, it is not humidified, it is very dry, so it goes inside your lungs, and then because of your difference in your moisture level, difference in your heat level of your air, it is going to sensitize your lungs. Due to sensitization taking place, okay, your epithelial cells as well as your mast cells, they are going to release pro-inflammatory mediators. Because of your release of your pro-inflammatory mediators, what you generally see is your inflammation is induced. So this can lead to your non-atopic asthma whenever you exercise in cooled areas. Exercise more amount of air in more volume, your mucus, it does not heat up your air, it does not moisten your air normally, so it enters into your respiratory tract, so your it is going to cause sensitivity, it is going to sensitize your epithelial cells as well as your mast cells, so they are going to release pro-inflammatory mediators. This mediators is going to cause inflammation, so you have your intrinsic or your non-atopic asthma. Lastly, your clinical features. So your attack of your asthma is generally characterized by dyspnea and wheezing. Okay, wheezing is common in case of asthma, not seen in case of your chronic bronchitis as well as your emphysema. And dyspnea, you feel very hard to breathe. And the chief difficulty lies in your expiration. I told whenever there is any blockage to your airways, it is more problematic for you to expire than to inhale. Okay, there is progressive hyperinflation of your lungs with trapped air distal to your bronchi. Okay, there is going to be a hyperinflammation, inflation of your lungs. Okay, attacks last from 1 to several hours. Okay, intervals between your attacks are characteristically free from overt respiratory difficulties. So these are episodic attacks of your asthma generally takes place. It is not like it is going to take place for a very long time. It takes place at a certain time, it disappears, and then again after some amount of time, after some hours, it is again going to take place. So you have your episodic attacks taking place. So it is associated with hypercapnia. Hypercapnia is increased amount of carbon dioxide, acidosis, and severe hypoxia. Hypoxia may be fatal. So there is hypercapnia, acidosis, and severe. Okay, why is there? So let's see why there is hypercapnia. Okay, so this is your respiratory tract. Okay, this is your alveoli. So in case of your respiratory tract, what generally happens is oxygen goes in, carbon dioxide comes out. This is your normal case. Now in case you are having asthma, there is obstruction over here. Now see, one of your cases that I've told you again and again is chief difficulty lies in expiration. Why is it so as well? So whenever we inspire, okay, this is your normal tract. You are not inspiring, you are not exhaling. So whenever you inspire like this, taking air, your lungs is expanding. So whenever your lungs is expanding, your airways is also expanding. Correct? It was this, you are inspiring, so you can see there is expansion in your airways. So even if there is any blockage occurring over here, due to your expansion taking place, you will be able to take in air, correct? So in this case, oxygen is going inside normally. Now when you expire, okay, this was what is happening during inspiration. So when you expire, same thing, the same airway is going to get contracted. Now there is a blockage already and it is contracting, so your amount of air coming out is going to decrease. You are going to feel pressure whenever you are exhaling out. You are going to feel pressure when you are exhaling out, correct? So in this case, if you are having problem in exhaling out, don't you think your amount of carbon dioxide coming out is going to be less? So amount of carbon dioxide coming out is going to decrease. Since there is decreased amount of carbon dioxide coming out, means carbon dioxide is going to remain back. So there is increased, so there is hypercapnia. Carbon dioxide is acidic in nature, so there is acidosis as well. So you are getting less amount of oxygen as well. Hypoxia, and with further go, it can lead to hypoxia, and which is generally fatal. And this hyperinflation also generally takes place because of your same mechanism that I've told you. Less amount of air is coming out from your lungs means what? More amount of air is staying back in your lungs, so inflation is there. Again you breathe in, again you are taking in more amount of air, you exhale out, again certain amount is remaining back. So what is it causing? It is causing hyperinflation. There is hyperinflation of your lungs. So this is it with your COPD.